Good morning. Subcommittee can now please come to order. Someone once said, I'd like mornings better if they started later, and amen to that, especially as a Californian. But I truly appreciate the effort that everyone has made to be here for a somewhat unprecedented 8 o'clock in the morning hearing. Although, as I said, as a Californian, my clock still says it's 5 o'clock in the morning. But seriously, when it comes to the topic at hand, there's no better time than right now to discuss it. Today, prescription drug abuse is a deadly serious and rapidly escalating problem all across America. We have an obligation to tackle it head on. The chair now recognizes herself for an opening statement. Since 2003, more than 5,000 U.S. servicemen and women have died in Iraq and Afghanistan. As Americans, we celebrate their lives and we mourn their deaths. They will always be remembered by a grateful nation. Yet today, there is a mostly forgotten war also being fought right here at home, in both small towns and large cities all across the United States. This costly and rapidly escalating struggle against prescription drug abuse and addiction is expected to claim the lives of some 30,000 Americans this year alone. For the most part, this battle is being waged in remote outposts of the human mind, where scientists now tell us that childhood trauma, genetics, mental disorders, stress, thrill-seeking social pressures, severe pain from injuries and illnesses, and yes, the horrors of combat, all contribute to devastating addictions, which in turn all too often lead to tragic and avoidable deaths. But what's even more insidious is the way these powerfully addictive drugs quickly turn people without any real emotional or physical problems into desperate people suddenly facing life or death problems. Few things are more destructive. According to the Centers for Disease Control, drug overdose is the second leading cause of accidental death in the United States, in large part due to prescription drug abuse, and the problem is growing every single day. According to a recent national survey, some 7 million people aged 12 or older regularly abuse prescription drugs, and there are approximately 7,000 new abusers every single day, many of them teenagers and young adults. That alarming trend is taking a huge toll on society. Today, the abuse of prescription drugs, especially painkillers, stimulants, and depressants, is the fastest growing drug problem in America. As someone who has been deeply and personally affected by this issue, I hope today's hearing will lead to a better understanding of the enormous scope of this problem, the staggering costs, both emotionally and financially, that it imposes on families and communities, and the need for a greater sense of urgency as a nation in addressing it. I believe one critically important first step is to do a better job of monitoring and limiting access to prescription drugs containing controlled-release oxycodone hydrochloride, including the popular painkiller OxyContin. Originally, OxyContin was intended to be prescribed only for severe pain as a way to help patients dealing with late-stage cancer and other severe illnesses. Today, however, more and more people across America are being prescribed OxyContin as well as other generic oxycodone drugs for less severe reasons, clinically known as moderate pain, greatly expanding the availability and potential for abuse of these powerfully addictive narcotics. For people all across America, prescription drug abuse is a day-to-day struggle. Over time, it destroys families and wreaks havoc on communities all across the nation. Someone with a toothache or a sore back should not be prescribed a potentially addictive painkiller. I agree that expanded public education plays a role in addressing the problem, but we're not going to make any real progress until we limit access to these powerful narcotic drugs and ensure that only patients in severe pain can obtain them. The pervasiveness of prescription drug abuse made national headlines recently when federal, state, and local law enforcement agencies, led by the Drug Enforcement Agency, cracked down on so-called pill mills in Florida, resulting in dozens of arrests, including 5 doctors. Congress needs to make it much more difficult for these rogue pain clinics to operate, and we should treat offenders like any other street drug dealer. By better coordinating the efforts of local, state, and national agencies, and by reducing the supply of highly addictive opioid painkillers, I am convinced that we can eventually save thousands of lives and spare millions of families from the headache and heartache of addiction. A recent Denver Post article highlighted why these powerful drugs are so attractive to thieves, drug dealers, and unscrupulous doctors. According to the Post, OxyContin costs $1 per milligram on the street and comes in doses ranging from 15 to 80 milligrams. So a dealer selling 1,000 tablets can make up to $80,000. What does that mean in human terms? Well, a recent report by the National Institute on Drug Abuse has found that nearly 1 in 20 high school seniors have reported abuse of OxyContin. And yet another disturbing report by the Substance Abuse and Mental Health Services Administration shows a staggering 400% increase in admissions of people aged 12 years and older for treatment of prescription drug abuse between 1998 and 2008. Clearly, we have a daunting challenge in front of us. I'd like to thank all of our distinguished panelists, especially DEA Administrator Leonhardt, ONDCP Director Kurlikowski, Governor Scott, and Governor Beshear for their personal commitment to the important issue. If we're going to win this fight against prescription drug abuse, we must all serve as the soldiers. The gentleman from Texas is now recognized for 5 minutes for an opening statement.
Madam Chair, thank you very much, and thank you for calling this most important hearing and for inviting so many experts that will create our 4 distinguished panels of witnesses. I need to apologize because I will be absent for part of the hearing, hopefully, and will be returning, but at around 8:30, I will have to go to another presentation, then hopefully come back, but we should have some members on our side of the aisle. I also wish to extend the apologies of ranking members Butterfield and Waxman, who are disappointed that they cannot be here at this time, obviously due to a conflict in commitments. According to the 2010 National Drug Control Strategy, the fastest growing form of substance abuse in the United States is the non-medical use of prescription drugs, including opiates, relievers, tranquilizers, sedatives, and stimulants. Under the careful supervision of a doctor, these medications can alleviate severe pain or help those suffering from mental disorders like psychosis, depression, anxiety, insomnia, or attention deficit hyperactivity disorder. Teens and young adults are increasingly susceptible to prescription drug abuse. 7 out of the top 10 substances most abused by young people are prescription medications. Like their older counterparts, teens most frequently obtain non-medical pain relievers, tranquilizers, and stimulants from a friend or a family member. Despite popular misconceptions to the contrary, research indicates that even teens and young adults misuse prescription drugs not just to get high, but for a variety of reasons. The Partnership for a Drug-Free America answers that teens do so to party, to get high, and in some cases, but also to manage or regulate their lives. They're abusing some prescription stimulants to give them additional energy and an ability to focus when they're studying or taking tests. They're abusing prescription pain relievers and tranquilizers to cope with academic, social, or emotional stress. Many teenagers draw key distinctions between these drugs and illicit street drugs, characterizing their use of prescription drugs as responsible, controlled, or even safe. Researchers have concluded that the growing popularity of prescription drugs also reflects the perception that these drugs are safer than street drugs. There are several programs at the federal, state, and local level that seek to curb prescription drug abuse and diversion. I look forward to the testimony of our witnesses so that we may determine what is working and what more can be done to stop the growing problems. And Madam Chair, unlike many of the hearings we have, and we have such contentious differences of opinion, I don't think we're going to have that today. I think we're just going to try to identify what works and that we move forward and lend the assistance at the federal level to everyone out there in attempting to curb a very serious problem. And I yield back at this time.
I thank the gentleman for his words and for the spirit with which he said them. And now the chair recognizes Mr. Pompeo for 1 minute.
Thank you, Madam Chair. I just briefly wanted to say thank you for holding this hearing. Thanks for bringing attention to this incredibly important issue. I'm the father of a 20-year-old son. I know the kinds of things he's seeing at Kansas University. I know the kinds of challenges that young people have with these, and I look forward to your testimony this morning so that we can get the facts, learn a little bit about what works so that we can develop good federal policy that'll minimize the risk from this very real concern that I think lots of parents have all across the country. So thank you all for coming this morning. Thank you, Madam Chairwoman. I yield back the balance of my time.
I thank the gentleman, and the chair recognizes Mr. Guthrie for 1.5 minutes.
Thank you, Madam Chairman. I won't take too much time because I'll speak a little later when our governor's here in the next panel. But I just want to thank you for bringing attention to this issue. It's important. It's important in my state, like all states, but we particularly have a problem, and we are looking forward to the next panel. But I just wanted to say thank you so much for having this hearing today. I yield.
Thank the gentleman and recognize the gentleman from Texas, Mr. Olson, for 1.5 minutes.
I'm pleased to be here early this morning and thank the chair for her leadership in holding this hearing to shed light on the problem of prescription drug diversion and abuse. I know this is an issue that is greatly important to the chair, and I commend her on assembling an impressive group of witnesses. Prescription drug abuse in America is not an issue we should take lightly. As a parent of 2 children, it's very concerning to me to see statistics showing that on a daily basis, 2,500 American teenagers are trying prescription drugs for the first time. 2,500 per day. The vast majority of these teens are getting drugs from their own house, taking them from their parents' medicine cabinet and using them or giving them to friends. Given this, it's so important that parents are educated about the risks of prescription drug abuse in addition to knowing about and utilizing drug disposal and take-back programs. I thank the chair for her commitment to America's youth. I look forward to hearing from witnesses. I yield back.
I thank the gentleman, and the chair recognizes Mr. Harper for 30 seconds.
Thank you, Madam Chair. And I certainly welcome the witnesses. It's quite an impressive lineup. We look forward to hearing what each has to say today. This is an important issue, and it has devastated families that I know back home. Spending years as a prosecutor, you see what it does to many unintended victims in this. And I just look forward to looking for solutions and ways that we can solve this and help these families. And I want to thank you, Madam Chair, for holding this very important hearing.
I thank the gentleman, and everybody's so happy this morning. The chair recognizes Mr. McKinley for 30 seconds.
Thank you, Madam Chairman. I join that. I thank you for holding this hearing this morning on this topic. No, as a father of 4, but a grandfather of 6, and I see what they're going to be facing. I saw what happened in our society back in the 60s. It wasn't pretty, and what these kids are facing today is shocking. My wife is a critical care nurse and works in the emergency room of a hospital, and she tells me time and time again of the horrors of so many people come in that have abused the drugs and what it's doing to our nation. So I welcome you and thank you very much for holding this hearing so that we can learn more how we can address this and save our next generation. Thank you very much.
I thank the gentleman, and the chair is pleased to recognize the vice chair of the committee, Ms. Blackburn, for 30 seconds.
And thank you, Madam Chairman. Welcome to our witnesses, and thank you all for being here with us today. There are 3 points that I think that as we work through what is an emotional debate that we need to be thinking about. First, to what extent should duly licensed prescription drug manufacturers be required to spend time, money, and resources on trying to envision every new way that their product might be abused? Secondly, if we begin to restrict the approval of new prescription drugs, what impact will it have on patients who desperately rely on them to cope with debilitating pain and are just trying to make it through another day? And perhaps the most important question is, how do we deal with personal and parental responsibility? And I yield back.
I thank the gentlelady, and the chair recognizes the gentleman from New York, Mr. Towns, for 5 minutes.
Thank you very much, Madam Chair. Let me thank you and Congressman Butterfield for having this hearing, and I also want to thank Congressman Gonzalez for filling in on his behalf. This is a very serious issue, and I am very pleased, however, that a number of provisions in the recently enacted Patient Protection and Affordable Care Act could yield some very positive results in our efforts to curb this growing problem. We must educate families about the dangers of loose prescription drugs in their households. We must also utilize other relevant federal laws and procedures in order to safeguard against prescription drug diversion. Some of these safeguards include a recently proposed risk evaluation and mitigation strategy. If implemented by the FDA, this strategy would train prescribers, catalog patient information, and administer periodic effectiveness assessment tests. Other safeguards would involve improving the communication abilities of our law enforcement officials, doctors, pharmaceutical dispensaries, so that frequent abusers can be brought to justice. Tackling the growing danger of prescription drug abuse will require bipartisan support. And that's the reason I was happy to hear the comment made by Congressman Gonzalez, that we are all on the same team when it comes to these kind of things and when it comes to protecting our young people. And I'm really happy about that. This public health issue requires the input and resources of all relevant stakeholders to ensure this problem is fully addressed. This is not one that we should get involved in the blame game. I think that there's enough blame here for everybody to share. I think it's time to come together to see in terms of what we can do on both sides of the aisle. Of course, every stakeholder that's involved in this issue, because this is an issue that if blame would solve it, then it would not even be here, because enough all over the years that we've been complaining about it. But I think the time now has come when we must roll up our sleeves and together work to see what we can do to be able to curtail the fact that, especially with our young people, who the numbers seems to keep going up and up. I look forward to this hearing from our witnesses today and working with my colleagues to ensure Congress plays a vital role in protecting families from the growing danger of prescription drugs. And let me say to the chairperson that I really, really appreciate her involvement here, and hope that we will continue to work together to see in terms of what we might be able to do to protect the lives of many of our young people who've gotten involved in this. And of course, I think that we can do a lot better. Thank you very much. I yield back.
I thank the gentleman, and now to move to the panel, we have the first panel, one of four that will be before us today. Each of the witnesses has prepared an opening statement that will be placed into the record. Each of you will be given 5 minutes to summarize that statement in your remarks. On our first panel, I'm honored that we would have these two distinguished witnesses, the Honorable Gil Kurlikowski. When I first met him, I couldn't say the name, and so I've come a long way. Honorable Gil Kurlikowski, Director of the Office of National Drug Control Policy, and the Honorable Michelle Leonhardt, Administrator of the Drug Enforcement Agency. Good morning to both of you, and thank you for your hard work, and you will each be recognized for the 5 minutes. You probably know the drill. There are lights over there, and as they're green, you are well on your way. When you see the yellow light, you're down to the wrap-up time, and when you hit red on the light, if you could then sum up your comments, and we will then move on to the next witness. So, Director Kurlikowski, you may begin with your first 5 minutes. Thank you.
Well, thank you, Chairman Bono-Mack, and thank you, Ranking Member Gonzalez, and the distinguished members of the committee for the opportunity to address prescription drug issues. I really applaud the committee's focus on this topic. Prescription drug abuse has been a major focus since my confirmation, and I've directed that the National Drug Control Program agencies address this epidemic in our country. Let me pause for a minute. As a longtime police chief in Seattle for 9 years, I paid attention to what caused harm in my community. Quite frankly, the abuse of prescription drugs wasn't on my radar screen, and quite frankly, I believe that around the country, this has not received the attention that it needs. Well, as the President's chief advisor on drug policy, this position demands that I raise public awareness and take action on drug issues affecting the nation. The efforts in the President's drug control strategy are balanced. They incorporate new research, evidence-based approaches to address drug use and its consequences. In 2008, over 23 million Americans ages 12 or older needed treatment for an illicit drug or alcohol use problem. However, only 11% received that necessary treatment for that substance use disorder. Well, today I'm here to talk about prescription drug abuse. Prescription drug abuse, as was mentioned, is the fastest growing drug problem in the United States, and it's categorized as a public health epidemic by the Centers for Disease Control and Prevention. And in recent years, the number of individuals who for the first time consume prescription drugs for non-medical purposes was similar to the number of first-time marijuana users. The 2010 Monitoring the Future, a national survey on youth drug use, found that 6 of the top 10 substances used by 12th graders were pharmaceuticals. We've also seen a 4-fold increase in addiction treatment admissions for individuals primarily abusing prescription painkillers. That was from 1997 to 2007. And even more alarming is the fact that over the last 5 years, emergency room visits linked to misuse or abuse of pharmaceuticals has nearly doubled. And at the same time, emergency room visits for illegal drugs like heroin and cocaine remained relatively flat. Furthermore, deaths from prescription drugs are increasing at a staggering rate, and state data show that 7 people in Florida, 4 people in Ohio, 3 people in Kentucky die every day from an unintentional overdose. The latest national data found that more than 27,000 Americans died from unintentional drug overdoses in 2007. Prescription drugs, particularly the opioid painkillers that were mentioned, are considered major contributors to the total number of drug deaths. And in 17 states and the District of Columbia, drug-induced deaths are now the leading cause of injury death. There are 2 unique reasons for the growth of the prescription drug abuse: easy accessibility to these drugs and the perception of risk. And for instance, persons age 12 or older who used pain relievers non-medically in the past year between 2008 and 2009, nearly 70% obtained the drug they abused from a friend or a relative. And research shows that because prescription drugs are manufactured by reputable pharmaceutical companies, they're prescribed by licensed clinicians, they're dispensed by pharmacists, they are perceived as safer to abuse than illegal drugs. And we know that's not true, and we know that young people aren't buying them in a piece of tinfoil from behind a gas station. In addition, recent studies found perceived prescription drug abuse as safer, less addictive, and less risky than using illegal drugs, and the drugs obtained from the medicine cabinet or the pharmacy were, in their perception, not as dangerous as those drugs that were obtained in other ways. A comprehensive approach is required to address the epidemic because prescription drug abuse problems pose unique challenges. It's important to balance prevention, education, and, something close to my heart, enforcement, with the need for legitimate access to the controlled substances was mentioned. Therefore, the administration has created an inclusive plan which brings together a variety of federal, state, local, and tribal groups to reduce prescription drug diversion and abuse. And while we have outlined our approach to this issue in the 2010 drug control strategy, the administration developed a separate plan focused specifically on prescription drugs. And next week, Director Lenhart and I, along with our federal partners, will release the administration's plan. Our prescription drug abuse prevention plan has 4 parts: education, prescription drug monitoring programs, proper medication disposal, and enforcement. And the first part of our response plan is education. Mandatory prescriber education as well as patient and parental education is essential. Second, each state should have a prescription drug monitoring program. These, known as PDMPs, are statewide databases that contain information on dispensed and controlled substances prescribed by healthcare providers. PDMPs should be interoperable and have the ability to share prescriber information. The third part of our plan calls for proper medication disposal. 70% of the people, as I said, reported getting their painkillers from a friend or relative, and we need to ensure that proper medication disposal programs are available. And in September, DEA held their National Take Back Day.
Excuse me, Director,
and
can you
collected over 120 tons. Let me just close and say that I thank you for your attention, and I really appreciate the witnesses that will be coming after me, and my heart as a police chief lies out to those that have suffered.
Thank you. Administrator Lenhart, 5 minutes.
Chairman Bono Mack and Ranking Member Gonzalez, distinguished members of the subcommittee, thank you for the opportunity to discuss the growing epidemic of prescription drug abuse. and the critical role of the Drug Enforcement Administration in the enforcement of our nation's drug laws and regulations. The diversion and abuse of pharmaceutical-controlled substances is a significant and growing problem in the United States. Every leading indicator shows increases over relatively short periods of time in the use and abuse of these drugs. Pain clinics have emerged as a major source of controlled substances for non-legitimate medical purposes. DEA and other federal, state, and local law enforcement agencies have developed great working relationships and continuously coordinate efforts to combat this emerging threat. Federal administrative and criminal actions against a physician with controlled substance privileges is rare. However, such actions are warranted when a physician is issuing controlled substance prescriptions for an illegitimate purpose and operating outside the usual course of professional practice. And as administrator, I've made prescription drug abuse a top priority for the DEA. I'm especially alarmed that another contributing factor to the increase of prescription drug abuse is the availability of these drugs in the household. In many cases, prescription drugs remain in household medicine cabinets well after medication therapy has been completed, thus providing easy access for non-medical users for abuse, accidental ingestion, or illegal distribution for profit. The 2010 Partnership Attitude Tracking Study, PATS as we call it, noted that 51% of those surveyed believed that most teens get prescription drugs from their own family's medicine cabinets. DEA manages a robust regulatory program aimed at preventing and curbing diversion all the way from manufacturing levels to the dispensing of these medications to patients. And in working with Congress, DEA also obtained new authority last year to regulate the disposal of unused medications by ultimate users, thereby getting unused medications out of household medicine cabinets in a lawful and safe manner. DEA is working diligently to promulgate disposal regulations, and in the interim, DEA launched a nationwide take-back initiative in September of last year, resulting in the collection of 121 tons of unwanted or expired medications. And I'm pleased to announce that DEA is planning a second nationwide take-back initiative on April 30th, and we will continue to hold periodic take-back events until regulations are in place. DEA's obligation under the law and to the public is to ensure that pharmaceutical-controlled substances are prescribed and dispensed only for legitimate medical purposes in accordance with the Controlled Substances Act. By carrying out this obligation, DEA strives to minimize the diversion of pharmaceutical-controlled substances for abuse while ensuring that such medications are fully available to patients in accordance with the sound medical judgments of their physicians. In this matter, DEA is committed to balancing the need for diversion control and enforcement with the need for legitimate access to these drugs. DEA closely monitors the closed system through record-keeping requirements and mandatory reporting at all levels through the supply chain. And due to enhancements to our regulatory resources, controlled substance manufacturers, distributors, importers, exporters, and narcotic treatment programs are receiving more inspections and audits than ever before. A key component to our enhanced investigative resources are tactical diversion squads. These are unique groups that combine the skills of special agents, diversion investigators, intelligence analysts, and task force officers. TDS groups are dedicated solely towards investigating, disrupting, and dismantling those individuals or organizations involved in diversion schemes. And as of today, DEA has 37 operational TDS groups across the country, and we plan to add an additional 26 more over the next few years. And one example of the effectiveness of these tactical diversion squads is an Operation Pill Nation, which targeted rogue pain clinics in South Florida since February of last year and culminated in a series of major takedowns in February of this year. This led to 32 arrests, including 12 doctors and 5 pain clinic owners. DEA also immediately suspended 63 DEA registrations and issued orders to show cause on 6 more, which resulted in the surrender of 29 DEA registration numbers. And this caused a ripple effect throughout South Florida and resulted in 50 more DEA registrations being surrendered. And in total, we closed down 38 clinics. So DEA recognizes that it can't solve this problem alone. DEA is working closely with our federal, state, and local and private sectors as a part of the administration's comprehensive approach to combating prescription drug abuse. Many states have also adopted prescription drug monitoring programs, which are deemed to be a valuable tool in curbing diversion. In closing, I want to commend the courage of those who are testifying later this morning for putting names and faces of loved ones to this problem, and I want to express my heartfelt sympathy on behalf of the men and women of DEA for their loss. I'm keenly aware that many others, possibly here even today, have struggled with drug abuse by friends and family, and DEA joins in this fight. So thank you for the opportunity to appear here today.
I thank both of the panelists, and I will recognize myself for the first 5 minutes of questions, and I will begin by asking both of you to turn your attention to the charts on your right. Although the data is old, 2007, 2006, would you both, just yes or no, fair to assume that the trend continues to grow at an alarming rate, that the numbers today are far worse than they were in 2006 and 2007?
Yes.
Yes.
Thank you. And Administrator Leonhardt, you were specifically talking about Florida. Can you tell me how many doctors have been convicted or have had their DEA registration denied or revoked for overprescribing Schedule II prescription drugs? When Governor Scott points out that 98 of the 100 top prescribing doctors who prescribe these painkillers, that they are in Florida, doesn't that send off a huge warning flag?
Absolutely, Chairman. The actual numbers of doctors across the country that have been convicted, prosecuted, I can get you those numbers, but I can tell you you're absolutely correct in that 90 of the top 100 are in Florida. And Operation Pill Nation identified those top doctors.
Can you tell me what took so long?
Well, I can tell you that the trends have changed. The pill situation, the pill mill situation in Florida is a rarely new phenomena. We first targeted the internet, which if you go back 4 and 5 years ago, drugs that we were finding on the street and we were asking where they came from, they were coming from the internet, and it was unregulated, uncontrolled, and our first efforts were there. It's because of the Ryan-Haight Act that Congress gave us, and our actions going after those organizations and individuals dealing on the internet, that we were able to basically shut those rogue internet sites down. And then we saw the shift over the last couple of years in Florida. We spent the last year identifying the pill mills and with a huge operation involving 12 of these tactical diversion squads. Over a period of a year, we're able to do those undercover buys that resulted in the takedown of Pill Nation. And we believe that that one consolidated takedown and actions over the past year will have a chilling effect on anyone attempting to open up a clinic or to continue in the same manner that they have continued over the past couple of years.
I see you have a chart on page 10 of your testimony that sort of reflects how effective the raids were. But I have a couple of questions for you just on basic math and perhaps to both of you. Some people will say that last year we took back 272 tons of unwanted prescription drugs. Does that not mean we're over-prescribing 272 tons of these prescription drugs? And if that's the case, can you explain the quota system to me? It seems to me that there's simple math that you all are overlooking in the quota system. You both have the ability to determine how much of these painkillers are manufactured and pumped out into our society, but the quota is just simply based upon demand. I will turn to both of you, or most specifically, if you even look at Florida dispensed more than 41 million oxycodone pills. The second highest prescribing state dispensed 1 million pills. Large states like California have dispensed fewer than 400,000. What a disparity. Doesn't that clearly indicate that there are probably 40 million extra pills in the supply chain if you look at that mathematical equation?
Let me mention, I think, two things, and you bring up an excellent point on the quotas. So one thing is that the most recent data for all of 2010, for the first time in 8 years, shows that the aggregate production of opioid painkillers actually flattened. So instead of seeing that incredibly steep increase in abuse and the increase in manufacturing, we also saw a flattening. I think as we brought more attention to this, it's going to be coming down. The other concern would be on trying to restrict particular quotas for particular drugs. Will just turn to a different drug with a different problem, and that could lead to subsequent abuse. So I think quotas is one answer, and I think that it needs to be more robustly looked at. And I think those questions, along with our FDA partners, are important ones. But I also think that we're beginning to turn the corner on not only the aggregate amount of these painkillers that are produced, but also on the registrants who will have to have the mandatory education, the number of scripts they write.
And I agree with Director Kurlikowski. 121 tons of pills were collected at the take-back in September. There's a number of reasons, a number of things we need to look at. Overprescribing you brought up as an issue. I believe that's correct, and I believe that it requires more education for the practitioners who are prescribing, more education for parents, more education for young adults and teens who are turning in amazing numbers to prescription drugs as their drug of choice. And DEA is looking at the entire spectrum, and we are striking at every level of the distribution chain. And our problem is that with quotas, we have a job to make sure that there is enough medication produced and available for patients in need. And we need to balance that with making sure that people that are not patients that have a medical reason for these drugs don't get it. So it's that balancing act. And the problem with quotas is also that no matter what we do there will still be a legitimate group of people that need that medication. And so we try to get that target number.
Excuse me, my time has expired. I just wish I would hear you focus more on the people who are dying from these narcotics and painkillers than worrying about getting more out there. To me, the problem is 30,000 people a year are dying. And with that, I need to yield to Mr. Gonzalez for 5 minutes.
Thank you very much, Madam Chair, and again, thanks to the witnesses. And I understand that once a drug is manufactured, there's only certain ways it gets out there to the consumer, and that's going to be, it's on the shelves of the hospitals or the pharmacists, and then there's the prescription written by the doctor. And so I want to talk about databases. The first thing that occurs to me is that the most effective databases, and you have to have the assistance of all these individuals I just indicated, those are the points of origin. So like you're going to deal with any problem, you got to figure out if you go there first and try to control it best you can, then we can deal with the other things that take the responsibilities of parents and such, is to make sure that there's not the availability of those drugs in the medicine cabinet and so on. And then there's some other issues, but I'll discuss it with another panel, and it's going to go to what the chairwoman was talking about, the amount of drugs out there and what we can do, or prescription drugs and what we can do. But until we really have, in my opinion, a truly robust and very effective widespread adoption of electronic medical records, health information technology, which is something that we've been attempting to do since I got here some years ago, I don't see how effective it's really going to be. Do you have any concerns about the abilities of all these different providers or points of origin to be able to access and to supply information in a manner that is timely and is going to be available, and of course, electronically based.
You're absolutely right. I think it's a shame that when we have to have a chart that goes to the most recent data of 2006 or 2007, the President's drug control strategy devoted an entire chapter to the fact that timely, robust, critical information on whether it's the drug abuse warning network, which a number of people brought into the emergency rooms, whether it's the number of people we test in only 10 jails in the country for the drug problems of people coming in to the jail regardless of what they were arrested for. All of that information is so helpful, and frankly, it's not timely, and it's not as relevant as it should be, and therefore it makes it difficult, I'm sure, for you in the policy-making area, and it certainly makes it very difficult for us in that area. So we have devoted this entire chapter to strengthening these kinds of systems, and I agree with you, electronic health records will be an important step forward.
Administrator Leonhardt.
Agree as well. And last June, we started the e-prescribing. I had signed for that and went into effect in June, and we're hoping that e-prescribing helps. I agree with you completely. And also, we do have 34 states that currently are using prescription drug monitoring program systems. And we see the value in doing that, how having a doctor or a pharmacist have the ability to look into a system and find out that someone has been doctor shopping or going from pharmacy to pharmacy has definitely assisted the states that have enacted those systems in preventing diversion.
And I know that we're always going to have this conflict. First of all, you have to respect confidentiality, the relationship for the patient with the doctor, the pharmacist, the professional, and so on. How do we balance all that? I mean, my fear is that one of the greatest impediments is people don't like the fact that this kind of information is going to be shared or is going to be made available. Now, I just believe that if it's made available to the healthcare professional, and in fact they act professionally, they're an incredible player or actor in this whole chain of how these drugs get out there. How do we balance the confidentiality aspects of it with, as we've said, a timely and robust database?
The PDMPs, I think the value in them is that they're designed by the states. So when the states enact them, they can put in the patient privacy and the confidentiality rules that they feel are best. They can also design them as to who has access to them. Some allow, at certain points, access by law enforcement agencies. But frankly, the practice of medicine is governed by the states. The boards of pharmacy and the medical boards in each of those states having access to those, including routine reports that are generated from the PDMPs, actually put the information in the hands of the people that have the power to regulate medicine within each particular state.
On your next panel, you have Governor Beshear here, and I know Kentucky is a state that implemented PDMPs, was very concerned about the privacy issues, and their systems have been up and running and have not had problems in that area. And as we look at the other 33 states that have PDMPs up and running, they've addressed those privacy issues, and that has not been a deterrent. That has worked, and that's why 9 additional states have moved and have pending legislation in their states and are moving towards PDMPs. They've worked those issues out.
Thank you very much. I yield back.
Thank the gentleman. The chair recognizes Mr. Guthrie for 5 minutes.
Thank you, Madam Chairman. In the interest of time, I just want to ask one question and throw it out to both of you. I understand that prescription drugs are more accessible to people in the family. They get them from family members. You know, a parent may have OxyContin in their house where they wouldn't hopefully have one that you'd buy typically would get on the street without prescriptions. But however, at what level is the prescription drug trade also in the organized crime, the drug cartels? And, you know, isn't just doctors overprescribing, or is there a whole network like you have in other type of drug issues?
I can tell you from our enforcement cases that, and we were surprised a few years back, we thought that they would act, there would be different organizations, they would act differently because they for the most part, are from the medical profession, they're pharmacists, and actually they are organized. We learned from Florida, these pill mill organizations, they're organized just like other organized crime and other crime groups selling coke and heroin.
Are they the same groups? Are the cartels organizing the pill mills, or is it different, different structure, I guess is my question.
I will say that they are, for the most part, different groups. We don't have a problem with prescription drugs coming from the Mexican drug cartels, for instance. This is one of those cases where the sources of supply are not in Colombia, are not in Mexico. The sources of supply are right here domestically.
I held a law enforcement roundtable last month in Buffalo, and one of the enforcement agents talked about a drug dealer in a particular section of the city in which heroin was being dealt, and then they had a subcomponent with a dealer dealing prescription drugs across the street.
Thank you, Madam Chair. I'll yield back in interest of time.
Would the gentleman just yield for one quick question?
Yeah, I'll yield to the
If
chair.
two just briefly can explain how many people are dying from the illicit drugs any longer as compared to prescription drugs?
The prescription drug overdose death, that is driving the numbers that have spiked so significantly. They cause more deaths than both heroin and cocaine combined.
Thank you. And the gentleman yields back, so the chair recognizes Mr. Towns for 5 minutes.
Thank you very much. Let me begin by, you mentioned the fact that there was 34 states using the monitoring system. Have you been able to detect that those states are using the monitoring system, that the problem is not as severe in those areas, those states?
There are two things that I think will be helpful in this. One is that there's a recent evaluation done by the CDC through a contract, I believe, on prescription drug monitoring programs. They're relatively new. Some are used more and some are more robust than others. So the other issue will be how can they exchange information across state lines. All of the physicians that I've talked to and all of the people that I have been privileged to be engaged with that have had these programs find them not only to be helpful in identifying doctors who may be overprescribing, but patients who may be doctor shopping, and the doctors themselves talk about it as a patient safety tool.
Right.
I will say that we're looking at the trends. Florida is ground zero for prescription drug abuse, and there is
Do they monitor?
There is no current PDMP in place in Florida. As we took action over the last year in Operation Pill Nation, we are seeing these pill mills actually move, and they're starting to show up in Georgia. Georgia is a state without a prescription drug monitoring program. So we are concerned. We believe that states that do enact prescription drug monitoring programs, that's one of the first things they can do to combat the diversion in their states.
Right. Is there any program in place to work with families that might be taking a certain type of medication that might be very susceptible to illegal use in terms of a drug? If it's in the cabinet that it's locked a certain way, is there any kind of training program in place?
And I think when you hear later on from General Dean and the CADCA group, and we fund through our partner SAMHSA 740 drug-free communities. Part of those coalitions will be, part of their mission is to educate people about the dangers of the prescription drugs. There are now lock-in medicine cabinets that have been made available. There are pill containers that have locks. But we also think the important part is bringing this to the attention of people about what's inside. As the chairman mentioned, when you collect 121 tons of pills across the country in one 4-hour period, thanks to the leadership of DEA, that should be, in my old job, a clue that we have a problem.
We have been able to use the Take Back initiative, and will on April 30th do the same thing, to make it not only be a way to safely dispose of your expired and unused medication, but also to educate. And I attended one of the sites on September 25th for the Take Back, talked to a number of people who showed up turning in their prescription drugs, and to a T, they all said they didn't realize they had the medication stacking up in their medicine cabinet because they didn't want to flush it. They didn't want to throw it in the trash in case someone else could get it. They didn't know what to do with it. So the beauty of the Take Back has been a way to educate families about how to secure the medications, and overall having people realize that they don't need to hold on to that medication, and that they have elderly in the home that could be confused and take the wrong medication, and they have young adults in the home, and that's the number one source of supply for them.
Right. Thank you very much, Madam Chair. I yield back.
I thank the gentleman. The chair recognizes Mr. McKinley for 5 minutes.
Thank you, Madam Chairman. I'm just curious, in the Appalachian area of this country that has such a high prevalence of misuse of, why is that occurring? Is that because the medical community is abusing their prescription authority? Is it, I just going to get a sense, why is one area so highly using pain-killing medicine?
We just spent 4 days, 3 days in eastern Kentucky and 1 day in West Virginia, and spent a lot of time asking people and looking at that, including interviewing 14 women who were in the jail system as a result, 13 of them for prescription drugs.
Could you speak up just a little bit, please?
13 of them as a result of prescription drugs. And what we found, particularly in Appalachia, was that one, people all know each other, and they can sometimes share those drugs that are in their medicine cabinet. Somebody has a back pain, and somebody else shares and says, here's something that I found helpful. The other problem came about as a result of people who had been prescribed a painkiller as a result of an injury. It could have been even a mining injury, and then ended up in a problem with that. It is a huge and significant problem, and we couldn't have made the inroads in understanding it better without the support of congressional staff that spent the 4 days with us there just less than 2 months ago.
And I would like to add that from our investigations and what we see, just as Kentucky, Ohio, Tennessee, we saw people that went down to Florida and would go to these pill mills. We saw that is a major source of supply for the pills that are on the streets in West Virginia. Junkets, people that, busloads of people that would go down to Florida, go to all these pill mills, get as many pills as they can, return to your area, and not only were some of them addicted themselves, but they'd have multiple.
I'm just struggling to understand why Appalachia. Why not Georgia? Why not Alabama? Why is it the Appalachian area is singled out for such high drug use, high painkiller use? I just wonder if they're not, if the prescribing physicians are, if it is the prescribing, maybe it is a pill mill, but what can we do? Because I struggle with it's just a region. I think it's a national issue.
It is.
I think neighbors in New York City know just their neighbors just as well as we do in West Virginia.
And you're absolutely right. As my travels across the country have clearly shown, this the prescription drug problem affects everyone, regardless of race, ethnicity, gender, or economic station in life. In particular, I think it gets more attention in Appalachia because of the abuse, and we heard a number of different reasons. I also think that it doesn't get quite the attention, perhaps in some places, because everyone that we met They're community-minded, they know each other, and there were no secrets. So if you had a friend or a relative as a result that was suffering as a result of prescription drug abuse, other folks knew about it. And but I think that bringing attention to it, I think the work that the congressional staff has done in both places, West Virginia and Kentucky, will make a big difference.
Thank you. Yield back my time.
I thank the gentleman. The chair recognizes Mr. Harper for 5 minutes.
Thank you, Madam Chair. Director Kurlikowski, as you look at this issue, are PDMPs the only option out there for states to implement the sharing of this type of information?
Right now, for looking at doctors who may be overprescribing or patients who may be doctor shopping, the only systems available are those state-run, statewide PDMPs.
Well, are there any state PDMPs that stand out to you as a role model for other states to follow that you really are impressed with?
As the administrator also mentioned, I think we're both very impressed with what has happened in Kentucky.
Okay. With that, I yield back, Madam Chair.
I thank the gentleman, and the chair now recognizes Ms. Blackburn for 5 minutes.
Thank you so much, and I want to thank you all for being here. Very quickly, just a couple of things. Listening to you, reading your opening statements, accessibility is the big problem, it seems, and you're trying to get into that. Part of that, as I mentioned in my questions to you, looking at both the education components with individuals, physicians, and I think also personal responsibility and parental participation in this. Let me talk just a minute to you, with you. Ms. Leonhardt, you mentioned state monitoring systems, the problems in Florida, the pain clinics as being a problem. In Tennessee, I mean, we've been talking about prescribing by physicians since the days of Elvis. And you know, how are you all working with that? If you're doing state monitoring systems, is there a method that you're using to incentivize or grant to the states? You know, what is your position on that, and how are you helping with the local and the state component of that? And if you want to submit this in writing, because I know we're tight on time, that's fine. But listening to you, it seems like if you're going to say, let's get to the crux of this, that getting to that linkage between your local and state agencies is part of the crux, and dealing with that overprescribing is another component.
We would be glad to submit to you after the hearing information on specifically what we're doing in Tennessee, and know that the law enforcement officials in Tennessee have worked with us, are partnered with us to do what we can to help Tennessee. And in many ways, they were kind of ahead of everyone, Tennessee and Kentucky, when it came to use of the internet. We learned from Kentucky and Tennessee, for instance, that there were all these deliveries being made to people who were ordering substances over the internet. Working with them, they helped us develop an internet strategy. So
okay.
They are up on the problem. They have worked with us on the problem, but I will provide additional information on that.
That'll be great. And articulate what you're doing with the grants and the incentive in. Thank you. Yield back.
I thank the gentlelady. The chair recognizes Dr. Cassidy for 5 minutes.
I will also submit a few extra questions for the record, but in the interest of time, limit myself. Ms. Leonhardt, in your testimony, you refer to civil penalties levied against McKesson, CVS, Cardinal. So what is the role of these intermediaries, and what is the role of the manufacturer in terms of controlling this problem?
Well, manufacturers and distributors have a part to play. They have responsibilities, and what we do at DEA is we make sure that we make them aware of methods of diversion and ways that their companies, their organizations can do more to prevent diversion. In these cases, our investigations showed over and over again that these companies were not doing enough to prevent diversion. So we used our administrative authorities, working with U.S. attorneys' offices around the country, we have brought more civil.
Well, let me ask you, just to be tight, I'm sure there's supply chain control. They can't. Are they required to report to you that Smith's Pharmacy in Dade County is ordering 500% more prescription drugs than you would think normally such a pharmacy would?
Yes, they have a responsibility to report diversion. They have a responsibility to report any suspicious order. And
define diversion.
I'm sorry? Define
diversion.
Diversion is where the controlled system for pharmaceuticals is not used, where pills and substances find their way outside of this closed distribution system. For instance, thefts, they're to report thefts and losses, but they're also to report pharmacies or rogue pharmacies that are ordering from them and ordering amounts that change or anything that raises a red flag that they are outside of their normal practices. We have investigated in many cases have actually started from tips from the companies who have reported these suspicious orders.
Okay, thank you very much.
Those that are not doing it, then we hold them responsible.
I yield back.
Thank the gentleman, and the chair recognizes the gentleman from Washington, Mr. Inslee, for 5 minutes.
Thank you, Madam Chair. Thanks for letting me join you today. Chief, thanks for your leadership here. Just wondering if you can give us an update on the implementation of our drug take-back legislation. And it's very timely. I just left Lisa Jackson, the EPA administrator, and we were talking about endocrine disruptors in the water system that are changing the basic physiology of fish and frogs in rather disturbing ways. So we'd like to know how we're doing on this.
Earlier, the remarks were made about truly what a bipartisan issue this is, and to see the legislation passed in both houses and the president sign it, and then DEA to be so involved and in having public hearings already to look at how to restructure the way that pills can be safely disposed of and not causing an environmental damage has been really heartening. We have had great cooperation from EPA. DEA is certainly the lead, and I'm sure the administrator can mention that. But we're making good progress, and I think the other part is the interim steps that DEA has been taking through the drug takebacks. The next one will be April 30th for your calendar.
Thank you.
And I will add that we did hold a hearing a few months ago. Over 150 witnesses appeared. We took their information, their comments. We're working that, and we believe that we will actually have a proposed rule by the end of the summer. We'll publish that proposed rule. That will go out for a comment period, and we will then review all those comments and move forward with a final rule. But it's on track, and the comments have come in. We're reviewing them, and we want to especially thank you for participating in that.
So what would you describe as your biggest challenges to make this actually work? You know, we have law enforcement is stressed. We've had reductions in the COPS program, and everybody has budgetary issues. If you were going to describe challenges that perhaps we could help you with in any way, what would you say they are?
Well, it's making sure that law enforcement has the tools to combat this at every level of the distribution chain, but it is also doing what we can. One of your panels has a number of the community coalitions and the community groups, the prevention groups. It's making sure that they are getting the message out and they're getting the support to be able to do that. It's working with doctors and prescribers and the medical community. It's what Director Kurlikowski and I will be announcing next week with this new prescription plan.
reauthorizing NASPR, removing the barrier that restricts the Veterans Administration from sharing prescription drug information. These are all things that Congress can actually do, requiring what will be proposed in mandatory prescriber education, those things.
Thank you very much.
Thank the gentleman. The chair recognizes Mr. Kinzinger for 5 minutes.
Thank you, Madam Chairwoman. Hi. In the interest of time, I'm going to keep this pretty short, and so feel free to do appropriately with your answers. For the Ms. Leonhardt, I've learned that certain companies are beginning to do a lot of reformulating of opiate drugs to make it more difficult for abusers to use and abuse the product. Do you believe reformulating has been effective in preventing the abuse of these drugs?
I appreciate the efforts in trying to reformulate so that they're not easily abused. However, I am concerned because we have seen with OxyContin that as soon as that was put out, we heard that there were, even on the internet, announcing ways that you could go around that. So we're very concerned, but we don't want to discourage industry from continuing to develop these drugs that can't be easily abused.
So have there been any, for either of you, any discussions about encouraging drug companies and generics to follow suit, or is this something that you personally feel is ineffective and not really worth pursuing?
I believe it is worth pursuing.
Okay, all right. That's pretty much all I have, unless you have something, sir. All right, I'll yield back.
I thank the gentleman very much and believe that concludes this panel. I want to thank our witnesses very, very much for your hard work on this issue, certainly the boots on the ground who are working this day in and day out and risking their lives to keep our society safe. We thank them all very much. Again, I appreciate your being here. The subcommittee will take about a 5-minute recess while we switch panels, so about 5 minutes. The hearing will come back to order, please. On our second panel today, we have two very distinguished witnesses who are both deeply involved in the issues of prescription drug abuse and prescription drug diversion, which obviously go hand in hand. We are honored to have Florida Governor Rick Scott and Kentucky Governor Steve Beshear with us today for perspective on how this battle is faring in their states. Without objection, I would like to yield 1 minute each to Mr. Stearns and to Mr. Guthrie for welcoming remarks. Mr. Stearns, you're recognized for 1 minute.
Good morning, and thank you, Madam Chair. I am delighted to introduce my distinguished governor, Rick Scott, to testify today on drug abuse, prescription drug abuse. He's a U.S. Naval veteran and a lawyer from Southern Methodist University, where he has a law degree. He started a business himself and met a payroll. He actually started Columbia Hospital Corporation and later became HCA. He's had experience with small business that he and his wife and family and mother started to eventually become a large business. He was elected the governor in this November 2010. He's the 45th governor in our state. He lives in Naples, Florida, with his wife, Ann, 38 years, and they have two lovely daughters. And I'm certainly very proud to introduce Governor Rick Scott. Thank you, Madam Chair.
And thank you, Mr. Guthrie. You're recognized for 1 minute to introduce your witness.
Thank you, Madam Chairman, and my voice is kind of raspy because Kentucky's in full splendor. Its bloom is there, and it is a beautiful place to be, and invite people to come. And in a month, we'll have the world watching us, which we're excited about with the Kentucky Derby. But it's pleased to have Governor Beshear here, and I can speak for the whole delegation on our side that we work together on this issue. We want to work with our governor on this issue and make sure we move forward in Kentucky because it is a big issue. We have a great state, a beautiful state, but this is a problem that we're exposing here today and we're working to address. And Governor Beshear has been involved in Kentucky politics since being elected president of the his UK class, I believe, the University of Kentucky. So just a few years ago, he got started in politics, but been in the General Assembly, Attorney General, Lieutenant Governor, and very active in civic life as an attorney in Lexington, and actually from West Kentucky, Dawson Springs, but practicing Kentucky in the Lexington area. It's really pleased to have you here. Unfortunately, he got elected in 07. I got elected here in 08, so we only had a year that we worked together in Frankfort, but enjoyed working with you and pleased to have you here today. Thank you.
I thank my colleagues and also join them, along with the entire subcommittee, in welcoming the two of you today. You'll each be recognized for 5 minutes. There are timers on either side of your table that will reflect green. As they turn yellow, that means you're, surprise, surprise, getting close to needing to wrap it up. And when it hits red, if you could come to a conclusion of your remarks as quickly as you can, we would appreciate it very much. So, Governor Scott, you're recognized for 5 minutes. And, excuse me, Governor, there's a button on your microphone, and
how's that?
Much better, thank you.
All right. Chairman Bono, Mack, and members of the subcommittee, thank you for convening this important hearing on the perils of the illegal distribution of prescription drugs. I ask that my full testimony be submitted for the record. During my campaign and since becoming Florida's governor on January 4th, I have heard firsthand the heart-wrenching stories from family members and friends of those who have lost their livelihoods and tragically their loved ones to prescription drug addiction. So I've been working on solutions to this problem since being elected. And Chairman Bono, Mack, I know you have been personally touched by this epidemic. Florida, like much of the nation, has a long history in the fight against criminal drug distribution. The names of the drugs have changed, but the problem has remained. Today, one of the most common names in the fight is oxycodone. Consider some of the statistics from my state, and the scope of the problem becomes clear. 98 of the top 100 doctors dispensing oxycodone nationally are in Florida. 98 of the top 100. Concentrated around Miami, Tampa, and Orlando. 126 million pills of oxycodone are dispensed through Florida pharmacies. By far more oxycodone is dispensed in the state of Florida than in the rest of the nation combined. The targets for law enforcement have often been the street dealers and addicts, essentially the bottom level of the distribution chain. One tool that focuses on end users is a database focused on the patient level. This month in Florida, my Department of Health began implementation of such a database. While the database moves forward, I'm working on satisfying the privacy concerns of law-abiding citizens. In 2009, the Associated Press reported a massive privacy breach when hackers broke into Virginia's prescription drug database. They obtained more than 8.2 million patient records and a total of nearly 36 million prescriptions. In Florida, I continue working with my legislative partners to find solutions that protect patient privacy. More important than computer databases, though, is focusing on the resources of my administration on a law enforcement solution that starts at the top of the distribution chain instead of the bottom. Every day, we see that pharmaceutical manufacturers and wholesalers turned a blind eye when massive amounts of narcotics stream into the same regions of Florida. Meanwhile, unscrupulous doctors work with storefront pill mills masquerading as legitimate health clinics. At each level, there is an opportunity for law enforcement to intervene and stop the illegal flow of drugs into our communities. In these first few months of my administration, I committed to provide a law enforcement solution, a statewide drug strike force. It ensures open channels of communication and multi-agency cooperation. The goal is clear: target the sources of these drugs before they hit the streets. It gives our local sheriffs and police chiefs a statewide coordinated effort that provides intelligence, analytical, and investigative support. As I speak to you today, local law enforcement strike teams are working to identify, investigate, and apprehend those in the medical and pharmaceutical distribution chains. I also directed all the state agencies in Florida to identify investigative resources, licensing and registration information, and analytical research that can be used by law enforcement. Florida Attorney General Pam Bondi is working with prosecutors across our state to ensure these criminals are prosecuted to the fullest extent of the law. I am grateful to all of these professionals for their commitment to this important work. Not only are these efforts focused on Florida, we are also coordinating with other states to shut down a national prescription drug pipeline that some have called the Oxy Express. We are aggressively working to shut down the illegal supply of prescription drugs from our state, both inside and outside of Florida. Since the beginning of my administration, there have been more than 50 arrests around the state, including a statewide sweep by law enforcement that raided 15 pill mills in 3 South Florida counties. Just the other day, I was disappointed to learn that a deputy sheriff in South Florida was the first drug trafficking arrest made since the initiation of the strike force. It is too early to go into the details on this and other cases, but I can tell you more investigations are underway and arrests will continue. With my partners in the Florida legislature, we will pass legislation in the next 3 weeks to prevent doctors from dispensing narcotics and require doctors divestiture of their pharmacies. Doctors who have forsaken their commitment to people's health in exchange for the quick buck of unethical and criminal dispensing must be put to an end. We'll also closely review the activities of wholesalers in Florida, and we'll put in place tough penalties for these manufacturers and distributors who fail to help us turn off the illegal supply chain. Let me conclude by telling you that this strategy, centered on a law enforcement solution and targeting the top of the distribution chain rather than the bottom, will make a difference. I applaud this committee for taking a serious look at the issue, and I want to ask you to also focus your energy at the sources of this problem. Together, if we hold the manufacturers, wholesalers, doctors, and pharmacies accountable, we can win this fight. Thank you very much.
Thank you, Governor Scott. Governor Beshear, you're recognized for 5 minutes.
Thank you, Madam Chairwoman, members of the committee. Thank you for allowing us to come here and discuss a national crisis that has been particularly destructive in Kentucky and in Appalachia in general, and that's the crisis of prescription drug abuse. Let me be frank. Our people in Kentucky are dying. An average of 82 Kentuckians each month fall victim to drug overdoses, the majority related to prescription drugs. That's more than 2 people a day. To put that in perspective, more people in Kentucky die from overdoses than from car wrecks. Greater still is the number of families decimated by the financial and social toll of this illicit drug use. In the words of our law enforcement officials, medical professionals, and coroners, what has long been a problem has become an epidemic. Our response in Kentucky has been aggressive. We've ramped up enforcement. We've expanded the availability of treatment, and we've implemented high-tech monitoring and record-keeping while working to share that information with other states. Our prescription drug monitoring program, called CASPR, was created more than a decade ago as a tool for both the medical and law enforcement communities and is now available electronically. Singled out by the White House in 2006 as a national model, CASPR is inclusive and easily accessible. Furthermore, In 2005, Kentucky became one of the first states to require a doctor's examination for the writing of scripts for powerful painkillers and to require internet pharmacies to be licensed in the state. 3 years later, Congress passed the Ryan-Haight Act. But these innovative efforts have not been enough, because as Kentucky has tightened its net, illicit drug users have found ready supplies of prescription drugs in other states with looser regulations, and we're not equipped to stop that. What is needed, clearly, is an aggressive nationwide response, one that recognizes that this country's prescription drug strategy is only as strong as the weakest link in the chain. I'm here to push three thoughts. One, I urge Congress to continue providing resources to the Harold Rogers Prescription Drug Monitoring Grant Program so that the work toward data sharing among states can continue. We've come too far with that program to stop now. 45 states have authorized prescription drug monitoring programs, and 34 are currently operating. At this point, I want to stop and salute the efforts of Congressman Hal Rogers of Kentucky. He has been a warrior on this issue of prescription drug abuse. Secondly, training must be mandated for those who prescribe controlled substances, especially Schedule II narcotics. These drugs and the risk of addiction and fatal overdoses must be more clearly understood by both doctors and patients. We can't leave this education simply to the pharmaceutical sales reps. And three, the Department of Justice must focus more attention and resources on Florida, especially South Florida, to stop the flow of prescription drugs. As Governor Scott and I have talked, it's a tremendous issue in his state, and we both acknowledge that. Some 60% of the prescription drugs sold and consumed illegally in Kentucky come from the loosely regulated pain clinics in Florida, with each trafficker bringing back, on average, more than $10,000 worth of drugs. In 2009, Kentucky State Police arrested more than 500 people from eastern Kentucky in its largest drug roundup ever, and every single suspect had ties to Florida. These pill traffickers are not amateurs. They're sophisticated. They're well-organized operations, and the fight against them must be well-organized as well. I appreciate the very aggressive efforts that Governor Scott is implementing in Florida to attack this problem. I appreciate the fact that I believe now they're going ahead to implement the monitoring system that they passed a year or so ago. And that, my friends, is good, but it is a start. As we both know, it is just a start. It's one piece of a much larger strategy that we have to apply. This is a national problem that demands national solutions. And the sooner we come together to recognize that, the greater our success will be. Thank you.
I thank both our governors and recognize myself for the first 5 minutes. I want to thank you both very much. I have encouragement, and the two of you are sitting together. For those in the audience, to recognize this is a bipartisan panel. And if you were to have only read your written testimony, you thought there would have been some sparks flying, but seeing that there's definitely a meeting of the minds here and a recognition, first and foremost, that the problem exists. Governor Scott, congratulations on your recent election. But to you, I'm encouraged to hear you are going to move now forward with but I'm also hoping you are going to continue to reject the $1 million that Purdue Pharma offered you. Are you going to accept or reject that $1 million that Purdue Pharma offered you to fund the database?
We're not accepting it.
I thank you for that very much. Can you speak, though, a little bit more? You came in as a businessman and you saw first and foremost that the law was being broken and you wanted to come at it from law enforcement. Can you speak a little bit more about this approach? Because I would love to see people go to jail. I would love to see some of these bad actors in handcuffs being taken off. Can you speak to your efforts a little bit more thoroughly from the law enforcement side?
Well, here's what we can do before we pass. We're in the legislative session right now, and so we have a very aggressive bill that's going forward that will help law enforcement. But in the meantime, we have a strike force. Our Florida Department of Law Enforcement, we took monies out of that budget right now, and we took a lot of investigators from the Department of Health and other agencies, and provided help to each of our sheriffs and each of our police chiefs because they're just overwhelmed with this issue right now. We've got, at the state, we've got a lot more analytical and investigative research that we can do. So we're helping them deal with that. On top of that, we have a very aggressive Attorney General. Attorney General Bondi is very aggressive on this issue. And so we've done a good job with the rest so far, but it's not even like we talked about it. There's 87% of the OxyContin that comes out of the country, prescribed out of the country, comes out of Florida right now. So the strike force is going to have a big impact, but I think a bigger impact is going to be the fact that the doctors will not be able to both prescribe and dispense. So that will stop that. They're not going to be able to own the pharmacies. We're going to have that. We're going to limit the number of prescriptions they can do a day. That will have a big impact. So it's just piece after piece after piece. And then, of course, as we know, they'll figure out something, then we'll have to continue to change. But I think all those things put together with all the data that we're helping our local law enforcement will have a big impact.
Governor, do you need any help changing laws up here in Washington that you have found? Are you changing state law?
You know, I think that probably the biggest thing we need to look at is regulating these manufacturers and what should these drugs be allowed to be used for. So I think the usage of it is. I mean, the fact that you can prescribe for these things. We're as Governor Beshear said, some of the things requiring the doctors to have to do a medical exam and all that. That already is being done, and it's never enough. There's always something else we're going to have to keep doing. But the first thing is, why are they even able to sell these things, and for what purpose? And shouldn't there be a much more limited purpose that these drugs can be used for?
Well, I look forward to working with you on these answers and moving forward, and I applaud that you're in the fight. And I also would like to mention Governor Kasich as a third governor who's become very involved. Governor Beshear, just a little bit of information. My parents fell in love and met before World War II at a little teeny tiny college called Berea, if you know Berea College in Kentucky. So it's a near and dear place to my heart. But you also came in here sort of loaded for bear, ready to set your sights only on Florida. But can you speak a little bit about what you're hearing the governor saying? You are encouraged about this willingness to cooperate?
Listen, this is not a partisan issue. This is a life and death issue, as we all know. And it requires us to work together. I don't know that there's going to ever be a total solution to this problem. It's always going to be with us, but we can sure make a significant impact if we work together and bring all the tools that we've got and cooperate together. You mentioned Governor Kasich in Ohio. We're working right now with Ohio trying to figure out how to share the information between our monitoring systems so that we can do an even better job than what we're doing.
I think, just in the sake of time, one of the biggest concerns, of course, is a privacy breach, and we're all very sensitive to that, and I think no more so any more than we are in healthcare. Can you speak specifically how you are protecting that data and consumers can feel confident that they have privacy that they need?
We've had the system now for 10 years, and we've got very strict privacy guidelines. It has had a successful track record. It has never been breached. It is a felony for folks to breach that system, and it's worked. The integrity of the system has held together. I don't know of any system, whether it's with the CIA or the State Department or the Defense Department or our monitoring system, that you can guarantee will never be breached, that will never find a way for somebody to hack into it. We obviously will continue to strengthen with the latest technology those security systems. But it's really a matter of weighing the issues here. There is a slight risk always, whether it's e-health records or whatever, that some breach can occur. But when you're looking at 82 Kentuckians a month dying, when you're looking at about 7 Floridians a day dying because of drug overdoses of legal prescription drugs, that's a pretty easy answer for me.
Well, I thank you very much. My time has expired. I recognize Ms. Blackburn for 5 minutes.
I want to stay right there with the privacy and the online database issue because we are the committee of jurisdiction with telecommunications and the internet. That's one of our subcommittees, and the privacy issue is one that we will do some work on this year. And Governor Beshear, you have had CASPER for 10 years, and I think it would be helpful to us as a committee as we consider both the larger privacy debate and as we look specific specifically at the prescription drug program, to have some guidance from you all, some suggestions of what you think we could focus on. And Governor Scott, let me just continue with the chairman's question to you. With these databases, what suggestions do you have, and where are you seeing the problems? Have you all come up with a way to guard against the breaches, and have you had any breach?
Well, we just started to implement ours. There was when I came to office, there was a lawsuit that prevented us from implementing it.
Okay.
So we're just now getting started, and so what we're doing is we're looking at what all the different states are doing with regard to privacy to come up with the best answer on dealing with that, because it's a big issue, and we have people worried about it.
All right. And Governor Beshear, did you say that you had or had not had a breach on your system?
No, we've never had a breach.
You have never had a breach in the 10 years.
Right.
So you feel like your firewalls and do you do an opt-in or opt-out on information and data share? Get back to me on that. I know time is sensitive.
I will. I'm not sure.
Okay, let's talk about education just a second, because this is something with the prior panel, as we had the DEA before us, that we looked on just a little bit, and I think that it is important for us to continue to move forward with education. I would like for you each to give me just a 1-minute response on what you are doing with public education, with personal responsibility education, with parental education. I know in Florida the pain clinics are a problem that was recently discussed, and then you have a little bit of history, Governor Beshear. So if you all would talk about the education component, that would be helpful. Governor Scott first.
Sure. Well, what we're doing is, first off, is making sure the public knows just through articles and things like that. First, just the public, make sure the public knows how big the problem is. I've done press conferences and things like that. I've brought it up through, we've had testimony in the legislature to talk about the issue. We've spent a lot of time this legislative session going through what the problems are. So that's the biggest thing we're doing right now.
Certainly the public education part of it in terms of talking about it publicly, and it's talked about a lot publicly in Kentucky right now. And I'm glad of it, because at least it's exposing all of our citizens to this dreaded problem. We're also, in our pharmacy schools, in our medical schools, we are pushing to make sure that our doctors really understand, the ones that are coming out, and the pharmacists understand what they're really doing, and that they don't get their information just from the drug reps. But they have the kind of information they need to handle these kinds of drugs very carefully and very effectively.
Do you think most Kentuckians realize you have the CASPR system in place?
I think there's probably a general knowledge we do, although it's probably not understood in terms of what it really does. But
thank you.
We're looking at strengthening that system. Right now, doctors can voluntarily be in it or not be in it. I'm thinking of beginning discussions about making that a little stronger. Making that a little stronger. I think doctors ought to be in that program.
Okay, thank you both, and I yield back in the interest of time.
Thank the gentlelady. The chair recognizes Mr. Stearns for 5 minutes.
Thank you, Madam Chair. Governor Beshear, when you mentioned that more people are dying from overdose than automobile accidents, that's appalling. That is just a frightening statistic. Governor Scott, earlier we had a Florida delegation, Madam Chair, so I heard some of the testimony from the governor. And I guess the question that came up when we had the delegation meeting and off at your questions too, can pain clinics be subject to additional scrutiny before they're licensed to practice? Is that a place where we could start?
Yeah, we're doing that now. We're doing it through, we already have where they have to be licensed.
Right.
So we're doing that, but it's not perfect. It's not easy to get around, but you can get around it.
Right.
So yeah, that's absolutely one of the things that's in our bill. And but the big thing is, think about this: we know the manufacturer, we know the distributor, we know the doctors that are distributing it. We ought to be able to just stop this if we just keep tracking it. Now, some people will change, and there'll be a new drug or something like that. But this is a legal distribution system that's doing it the wrong way. So we ought to be able, if we track it all the way and have criminal penalties and civil penalties for everybody that's doing the wrong thing, I think will have a dramatic impact in Florida for a period of time, and then something will change.
Governor Beshear, anything you want to add to that?
No, I think we need to be as aggressive as possible in all of these areas. We need to be aggressive in regulation of all of these folks and regulation of what the pharmaceutical companies can do in terms of who gets these drugs and how they are dispensed. We need to be very aggressive in the law enforcement area. And I think what Governor Scott is doing in Florida is showing that kind of commitment very quickly, and we've been doing that in Kentucky for some time also.
Intuitively, the relationship between the doctors and the pharmacies, is that anything that you as a governor, either one of you, can do in terms of educating or threatening or somehow trying to influence the relationship between the pharmacy and the doctor? Or is that sort of sacrosanct that there's nothing you can do?
We're doing it in our bill. We are the doctor that prescribes will not be able to own a pharmacy.
Oh, that's good.
So we're going to completely separate it, and then we'll have the data of we'll be able to track all the way through. Yeah. So, but I think stopping the ownership will have a significant impact.
Is there any state that has in place some of the things you've already talked about, Governor?
I haven't seen anybody that restricted the ownership of pharmacies.
Okay. Okay. Yes.
One of the other things, and I'm not sure how his laws are set up, but I appoint the doctors to the Board of Medical Licensure and the pharmacists to the Pharmacy Regulatory Board, and I have made it a very clear point before I appoint anybody. I have them come in and we talk about these kinds of issues, and I get a commitment from these folks to really bore in and try to address these kinds of issues as much as possible. And I think that's just another tool that we have to attack this problem.
Now, is there anything that the federal government, either one of you, think we as legislators on the federal side, or perhaps direct the federal agencies in some way that could make your job easier so we can stop these drugs from coming down the pipeline? So any suggestion you have would be very, very helpful. Governor Scott?
Sure. I think the biggest thing is why, I mean, there ought to be restrictions on how these drugs can be used and what they can be prescribed for.
From the federal level?
Yeah.
Okay. From the FDA?
Right.
Okay.
Another area that I hope that you all will pay particular attention to are continued funding for the Hal Rogers Act that's on the books now. That will help the states to share information and develop the systems to share information, and that will be effective in this battle. The HIDA, the Burns JAG awards and grants that are made that help us fight this specific problem. I know that just as Governor Scott and I are fighting budget battles every day, you all are too, but some things are more important than others. And that's the way we all have to look at the way we balance our budgets. That's what I do. That's what he does. And I just ask you, in that priority, put this priority up there.
Well, I want to thank you. My time's expired, but I think the fact that both of you governors took the time to come up here to talk about this serious problem, I think is accommodation to you and also for us having this hearing, Madam Chairman, because this shows that even though we're all trying to reduce spending up here, this is a priority, I think, that is very serious in this country, and we have ways to stop it. So thank you for your testimony.
Thank you, Mr. Stearns. Mr. Guthrie, you recognize for 5 minutes.
Thank you very much, Madam Chairwoman. And also, your roots are from Muhlenberg County, or several generations back, I believe.
That's right.
Which is near where the governor's from, with a couple of counties over where the governor's from. So thanks so much. And I didn't mention the First Lady. She's from my area, so my home area, so I should have mentioned that in the introduction. So I appreciate what she's doing as well for our state. When we did Casper, I remember it coming forth, and I will tell you, there's not a legislative session that doesn't go on that, particularly the legislators from Appalachia, Robert Stivers, a good friend of mine, the Speaker, now Speaker Stumbo, have always pushed what can we do to improve monitoring, interdiction. I think at one time when burn grants weren't funded, a couple of years ago, the state came in and helped with our multi-jurisdictional task force. So the Kentucky leadership is focused on this and trying to to help solve this problem. But I think we tied in, if I remember, some of the participation into Medicaid, because it seems that the prescription drug problem is in areas that are heavily Medicaid as well. And I don't know if you, just the correlation between that, or if you've seen that as well, Governor.
Certainly, you know, prescription drugs are allowed under the Medicaid program, obviously, and every state is involved in that program, and you're going to have some abuse within that program, and we're very aggressive in the Medicaid area of trying to weed that out, and at the same time, educate people. You know, we're pushing in the Medicaid program the ability of our local health departments and those regional medical centers to educate our folks about the dangers of these narcotics. You know, so many of these people that end up being addicts start out as legitimate drug users, you know, that they need something for their pain or this or that, and they start out in a very legitimate way, and then they end up being addicted, and then they get into this cycle of buying the drugs illegally, and that just grows the problem.
And I know you weren't governor at the time, but when we passed Casper, I don't remember Florida being such a big issue for us 10 years ago. But did it just move to, because I-75, wonderful highway, we love I-75, but and people go to Florida and enjoy it and love it, but it also seems to be a pathway for the prescription drugs to come to Kentucky. And is that because we had Casper, so it stopped or helped curtail some of the problems we had, so it's just moved?
Sure. You know, before we had Casper, they would just stay in Kentucky and get these drugs illegally, and we haven't cut all of that out. I don't want to even imply that, but we made a significant impact in it by having this monitoring system among several tools that we have. And the fact is, no state's an island. You know, folks, if we stop them doing something in Kentucky, but they can do it across the state line, they'll go do it across the state line. And that's why it's so important for all of us, all across this country, to find ways to address this. It doesn't have to be uniform everywhere, but it has to be everywhere for this to really work.
Well, thanks. And I think I saw you on the news a couple of weeks ago, and I know Florida's in session, and I guess a bill had seemed to have failed in Florida that might have addressed this, but it sounds like Florida does have a bill moving forward in the legislature now. I don't know if it had stalled or whatever, but I remember, Governor, I'm glad to see y'all together working on this because it's a problem for all of us. But what's going on in the Florida legislature to address the program or the tracking or the similar Casper deal?
Well, first off, the monitoring bill was passed last year. So there was a lawsuit that just got settled. That just got finished last Friday, I think.
Maybe that's what you were referring to.
Yeah, so that's finished. But we have a very good bill that looks like it's going to get out of both the House and the Senate, which everybody's signed off on, including the Attorney General, who's very focused on this. And it's if you prescribe the drug, you can't dispense it out of your office. You can't own part of a pharmacy. There's a restriction on the number of prescriptions you can do a day. We've got temper-resistant pads to write the prescriptions. We've got licensing of the pill mills. So we've got criminal penalties, civil penalties, going all the way up to the manufacturer. So, because we're going to try to do everything we can to stop it, because it's a big issue. When 98 of the top 100 doctors in the country prescribing oxycodone are in Florida.
So is Florida's laws different? Because I-75, you got to go through Tennessee and Georgia to get to Florida. Are y'all just so different? I know you're working on that, but is it so different now, the current status, than even Georgia or Tennessee? I mean, Kentuckians aren't going to Tennessee; they're going to Florida. So that's what's the difference? I guess
every state's been different.
And what's happened is that some of this is starting to move to Georgia because Georgia doesn't have a monitoring system. Tennessee does, and that's, I think, initially what pushed it south. And you know, Georgia may be the next place that we really have to push hard to get them to address this situation.
Well, thanks, Governor. Thanks for making the trip to Washington today. I appreciate it. Thanks.
Thanks.
I have to go back now. I'm out of time.
I thank the gentleman. Mr. Harper, you're recognized for 5 minutes.
Thank you, Madam Chair, and welcome to each of you, and it's an honor to have you here, and thank you. This is a very important issue. We all have friends who have had their families devastated, primarily by young people who get those prescription drugs from their medicine cabinet at home. That's what seems to be a major problem. So how do we solve the underlying problem here is that no matter what regulations we put on, which will be very helpful, how do we convince these young people not to use the drugs, not to take them? Are you doing anything in conjunction with, say, success in, say, drug courts or in any faith-based programs? Governor Beshear, I'll ask you that first. So any coordination there?
Yes, we have drug courts. We have faith-based initiatives that all work in this area. Obviously, a part of it is education, and we're pushing that both in the public school system as well as through faith-based initiatives. The other end of it is treatment and rehabilitation. And we took a significant step recently in Kentucky by revising a major part of our correction system and our approach to corrections to put a lot of time and effort into treatment and rehabilitation so that we can stop recidivism and stop that revolving door to where folks just get out, you don't give them any help, you just turn them loose again, and within 30 days they're out trying to buy the drugs again and they're back in. And we brought the Pew Foundation into Kentucky and had a bipartisan effort of Republicans and Democrats, our House, our Senate, our Supreme Court, and the court system, as well as the governor, all got together. And we've made some major changes that I think on that end of the spectrum will address the recidivism rate.
Great. And Governor Scott, your state on dealing with, say, drug courts or faith-based initiatives to help in this effort, what is the story there?
Well, the big thing we're doing since I've been in office is educate the public to make sure everybody gets on board. First off, making sure we get this legislation passed. So it's very important to get that done. The strike force is very important. On top of that, just continue to educate the public. Our schools are educating the public. We also are, the individual I put in charge of Department of Corrections is very focused on this, and same thing as Kentucky, very focused on the number of people that get out of prison and go right back and have the same problem. So he is somebody that's very focused on that issue.
Well, obviously our goal is to make sure they never get into the court system in the first place, and how do we encourage folks this is not the route to go?
Well, one thing we've done is our juvenile justice is run by an individual that from Miami. She came up to work with me, and she's focused on a program that she's worked for 20 years in Miami that has had a dramatic impact in stopping sort of the first time you get stopped for something, you don't end up in prison just because it ends up being a cycle. Right. So all the things she's done, starting with civil citations and starting with if you get stopped the first time, it's not just that issue. You might have an issue over food, shelter, family issues, things like that, and having a holistic approach to it to stop them from ultimately ending up in prison. So we're taking all the things that she's doing and spreading them across the state. On top of that, we have legislation that would allow us to do a civil citation program rather than immediately move it into a criminal program.
And how you secure the prescriptions at someone's home so that no one other than the intended patient gets it is a really tough thing to do. As far as I'm interested in what you said about your task force that you have in place. How are you going to measure the success or success of the mission of that task force? What are you anticipating or hoping for out of that?
Well, the numbers have to get better. We can't have 98 of the top 100 doctors, 126 million pills. Now, it's basically how do we stop just basically all this happening in our state? But it's going to be arrest. It's going to be the number of prescriptions that are done. In the end, it's prescriptions and death.
Okay. What about in working in conjunction with your state medical association? What input have they given either of you?
Well, in our case, they're very focused, and I'm doing something similar because I have the opportunity to appoint the members of the Board of Medicine. And so as I'm going through that process and talking to individuals about those positions, and I've talked to them about how important this issue is and the fact that they've got to be engaged, and the Board of Medicine has to be engaged.
Governor Beshear?
Same thing here. You know, we're engaging the medical profession, the pharmacy profession, as well as their regulatory boards. And, you know, as I'm sure Governor Scott would point out, those boards, their first duty is to protect the public. Sure. And not just protect themselves. And we see a little bit of that in every regulatory environment, whether that's lawyers, doctors, pharmacists, and I'm a lawyer, so I can say that about myself. But, you know, we've got to emphasize that their first duty is to the public and to protect the public, and it just comes down to appointing the right people.
Thank you each for being here, and Madam Chair, I yield back.
Thank the gentleman. The chair recognizes Dr. Cassidy for 5 minutes.
Thank you for being here, gentlemen. My pain doctors really like the PDMPs because they feel like the pill mills give everybody else a bad name. Right. Now, that said, I gathered that from testimony that some of these PDMPs are robust and some of them are limited in ability. Now, Governor Scott, clearly you have legitimate concerns regarding the privacy. But as much as you can say, and I gather Kentucky has a rather robust program, where do you imagine yours will be on the spectrum? And I just mentioned that because at the previous meeting, Florida was described as ground zero for the promulgation, if you will, or the source, if you will, for these drugs across the nation. So just to ask you.
Well, it's clearly ground zero. So it's a significant issue, and the things that are Florida's problem is a problem for the whole country because we haven't stopped the abuse. So our database will be what we're doing is being one of the later states to do it. We'll be able to take all the benefits, take all the knowledge from the other states, which is what we're doing, both on to make sure we have the right information and also have the right privacy concerns that we can address. So we'll be doing both of those. But on top of that, we're gonna make sure we're tracking from the manufacturer to the wholesaler to the doctor, not just at the pharmacy after the fact, because after the fact is going to be a part of what we do, but I think the biggest part is going to be we're going to stop the distribution of it.
Yeah, I see that. Yeah, okay. Now, let me ask you, my pain doctors also tell me part of the problem is that someone may live on the Pearl River borders between Louisiana and Mississippi. And I think there's a Pearl, Mississippi and a Pearl, Louisiana. And they say they will live in one state and go to the other. And they will get as much as they can below the threshold here, and then they'll go back here. And they will do it as well on the other side. Now, clearly, that just may require a federal overlay. But as two fellows who obviously will be jealous and respective of states' prerogative, how do we keep folks from popping across state borders to maximize? You see where I'm going with that, Governor Beshear?
Well, first of all, both states need the monitoring program. And do both of them have that?
They both do, but but each is self-contained.
Right, and they need to be doing what we're doing with Ohio right now. We're sitting down and trying to work out how to share information, and we're going to do that. Governor Kasich and I will end up. We'll find a way to do that, and we're being helped by this Hal Rogers grant program. That's the money that's been provided to help states work to share information in these monitoring systems, and we need to continue that. We need that funding to continue doing this so that every state ultimately will be sharing across state lines. That's the only ultimate way that these programs will be as effective as possible.
So, so although you start off with Ohio, you share a border, you actually envision that eventually you may partner with Governor Scott, for example.
Yes.
And wherever there's a potential distribution, be able to go there.
Yes. We all need to partner eventually so that there is no place in this nation that people can go and be able to do what they're doing now as freely as they do it.
Now, Governor Scott, I have to admit, I'm just, I'm a gastroenterologist, which I tell people prepared me very well for Washington, D.C. So what I'm about to ask you seems very simplistic, it may be. But it seems like if you know who those 98 docs are, all you need to do is have an undercover person walk in. I'm told these pill mills that you pay $250 or something for a visit. 5 minutes later, you walk out with a handful of prescriptions. it seems like you could go to each of these and put them out of business for inappropriate prescribing. Why not?
The difficulty is that you know, the smart ones, what they're doing is it'll appear legitimate. They'll do the MRI. They'll do the history. They'll do all these things that you know. So it's not as easy as just walking in and saying that you're doing something wrong. You've got to have. That's why we spent a lot of time on this legislation with the Attorney General and with the sheriffs and the police chiefs to make sure that what we're passing is something they're going to be able to convict with, because they'll do all everything I've been told. They'll do all the basic things to make sure it's very difficult to stop them.
Will the gentleman yield just 1 second?
I will.
I would think if you just let out the word that you're going to do sting operations, I mean, I would think that would create a pale over those physicians that might retard them from doing this. So I know, Governor Scott, it sounds difficult, but I think what the gentleman's saying is that the fact that these stings might or might not come would create some caution.
I think the difficulty is there's a lot of money in this.
Greed is.
There's a lot of money being made.
Thank the gentleman. We are fortunate to have the governor, as I understand, until 10:15, so we'd like to do a second round of questions until that point, if my colleagues are so inclined, and I will recognize myself for the first 5 minutes. And just point out a few things I think that are essential for this discussion. First and foremost, it was my understanding that OxyContin was originally approved for severe cancer, late stages of cancer, for severe pain, yet the #1 prescriber today of OxyContin to children 12 and over are dentists, and I think that should be pointed out. I'd also like to talk a little bit about the parental education words that keep coming up, and point out that we have 2 panels yet to speak who will show that parents of all walks of life are affected by this, and that it is impossible to detect this problem until it is too late. Governors, in your travels and your meetings with addicts and loved ones of addicts, first of all, would you be I contend that OxyContin is heroin. And would you take big umbrage with that? Would you say that's about right, what you're seeing in the?
You never know the definition, but I can tell you, we ought to really restrict what it can be prescribed for.
I have a bill that just does that, and I'll be looking forward to working with you on that. You keep speaking also, Governor, about limiting all of these leftover pills in the medicine chest, and I keep wondering why we're prescribing, hundreds of tons of pills a year that go unused. Patients don't want them. Why are they getting out there? That's another question that I look forward to exploring with you. And Governor Scott, I want to applaud you on your decision to reject the $1 million from Purdue Pharma for your database. Just as recently, there was an article here that points out that the CDC authored a study where they linked these powerful painkillers to deaths, and then the University of Wisconsin School of Medicine released a study that disputed that and talked about liberalizing opioids, and lo and behold, financed by Purdue Pharma, and I'd like to submit this article for the record. And I think people need to start looking at the connection between these studies and these policies and the big money that you were just speaking about, Governor Scott. So, Governor Beshear, clarification again, if I might. You did say the number of fatalities in Kentucky from drug overdoses has now surpassed automobile accidents. Is that legal or illegal drugs again?
It's a combination, but the majority of it is legal drugs, abuse of legal drugs.
Thank you. And then Governor Scott, as a businessman, when you look at the chart for the dramatic increase of opioid abuse, it's ironic that the trend line started screaming upwards shortly after OxyContin was approved. As a businessman, does that look kind of fishy to you, like it does to me?
Yes.
Thank you.
Oh, you should see if you look at my testimony, you see how many, 87% of it coming out of Florida too, and just a dramatic increase. It's just.
Thank you. And another point, and as somebody who has spoken publicly about my family's problem with this, or being involved with this, the disease of addiction, and it is a disease, and I'm happy that Congressman Harper brought up that side, that they shouldn't be necessarily in the courts, but we should treat it as a disease first and foremost. But as governors, when you meet the families that are suffering, aren't these just normal families, regular families? I can show you stacks and stacks, and I know you have the pictures too of kids who are in their senior year of high school. One family member whose son died just a week before his graduation from high school, and he was an all-star athlete on the dean's list. Everything is right about these kids. Do you believe, like I do, that when these kids get access to these powerful painkillers, they don't stand a prayer and the ability to stay off of them?
This cuts across income brackets. It cuts across every bracket. This is a problem that everybody is having, and I don't know that there's anyone in my state or any other state anymore that doesn't know somebody, whether it's in their own family or a friend or another family that's been affected by this.
Yeah, I mean, just a good friend of mine's 18-year-old just died 2 weeks ago, overdose. He found her, and it'd be horrible. But it impacts everybody.
Do you believe? Was your friend aware that his daughter was using?
He had he'd found out. He'd sent him to a program, but then what happens to a lot of people is that the kids turn 18. They don't have to be in a program, and so.
There's a mother who will speak to that on the next panel, to that very thing. Last thing, have either one of you ever met somebody who wanted to be addicted?
No, but I have a family member that's been addicted his whole life. Never beat it. Started at a young age and never beat it.
And it is a lifelong struggle. Again, I thank you two very much. I look forward to our continued working relationship, and again, I appreciate your courage and being here today. And the chair, I will now yield to Ms. Blackburn for 5 minutes.
Just to follow on, Governor Beshear, you mentioned you were thinking about putting your program as a mandate. And as I've said here, listening to you all respond to the questions, I'm thinking, it must be very difficult, and you may have some guidance for having a program that is an opt-in for your pharmacists and your physicians. And it seems as if those who are illegally prescribing or illegitimately prescribing, over-prescribing, would choose not to use the system. So I wonder if you would just explain a little bit about what has led you to that, and as Governor Scott is setting his program up, what would you advise him? Would you advise him for it to be a mandate from the get-go?
Well, I'm going to be sitting down with our medical licensure board and our medical association and the dentist and the pharmacist and talk about this. But so far, it's proven effective the way it's set up, in that the doctors that are using it can actually detect other doctors, even if they're not using it, that are over-prescribing and are abusing the system, as well as being able to detect those.
So you are using it as an accountability tool, even for those that are outside of the system?
Yes.
Okay, that's great. Now, how do you pay for your system, and what's the cost of it each year?
It's paid for by state funds.
Taxpayer dollars.
Taxpayer dollars, and
Okay.
I'm not sure, I can't tell you offhand
If
what
you
it
would
costs,
submit
but
that.
It costs a fraction of what it costs to handle the problem the other way.
All right, and Governor Scott, you said you're not taking a grant that was offered to you, so how do you all intend to pay for your system?
We have funding from other individuals and companies that are putting the money up.
Are they
So
pharmaceutical companies or?
No, we've got 2 years of funding right now. Ours is, we're just starting to implement ours.
Correct.
But no, it's not pharmaceutical companies.
So it's private funding?
Right.
So there is no taxpayer dollar involved?
No.
Okay, thank you. I yield back.
Chair recognizes Mr. Guthrie for 5 minutes.
Thank you, Madam Chairwoman. Again, I think that if I remember the problem we were trying to define it in the legislature, it seemed to be Medicaid, where if you have private insurance and they limit how many prescriptions you can get over and over, and we had to address that with the Medicaid because it just seemed that's where a lot of prescriptions were coming. Not everyone. It cuts across all swaths of people, but the concentration of it was. And Mr. McKinley, you weren't here, Governor Beshear, earlier, but Mr. McKinley asked the question to the panel before, to the Drug and DEA, about why it's Appalachia seems to be in a bigger deal. And because in my area, because it's not only Appalachia using drugs in Kentucky, I can tell you that. In my area, though, it's methamphetamine. So every time we'd show up for Frankfurt for our legislative session, groups of us were trying to fight meth, and the other groups were fighting this, but it does seem the prescription drug part of it is concentrated in Appalachia, where in my area it's the illegal manufacture of meth. And do you, have y'all, I don't know the answer to that, and I thought it was a good question, why he said earlier. I don't know if your task force, if y'all have looked at it that way, why Appalachia seems to be more the prescription side. Maybe it's I-75 access to Florida versus our area is not that way. I don't know.
Well, it's obviously a nationwide problem. There are, I think, concentrations of prescription drug abuse in some places. There's concentration of things like meth
in my area
and illegal drugs in other places. But it's obviously, it blankets the United States, and it's getting worse, not better.
That's our point. You know, when we come to Washington and talk about problems in our state, that we have to do that. But obviously, we have and you're the governor of my favorite state, and obviously a beautiful place. But we have to talk about these problems, and we have to get together and try to solve them. So, thank you very much for being here today.
Well, the first step is to recognize that we've got the problem.
I think the Governor Scott wants to comment.
And one thing somebody just told me that there's no state taxpayer dollars, but we are going to get some dollars from the Hal Rogers federal grant, but there's no state taxpayer dollars.
Thank you for the clarification. I think
if you want my time, Madam Chairwoman, I'll yield you my time back. Or?
Oh, thank you. I was taking it anyway.
Okay, go ahead. I was.
But thank you. I think the important point, too, is whether or not there was other pharmaceutical money involved, which is a question that we debate here on many things. But in this specific instance, I thought the Purdue Pharma, your decision was a good one. And I applaud both of you to wrap it up and to thank you for your time today and your spirit and the willingness to truly address this problem. We're not going to end it. We're not going to solve it entirely. But I do believe good, innocent people are suffering and crime. It's a very basic situation for me. The FDA approves and regulates, and the DEA is supposed to control. And with statistics like that, it shows that we're failing. And it's time to stop. Too many people are dying, and too many of our constituents, and more of my colleagues would have participated today. I know Congressman Vern Buchanan is very interested now. Congressmen from Massachusetts are very interested. This is not only Kentucky and Florida, it is nationwide. And as the panels go on, we'll focus on California and what is happening. So Florida, don't feel that it's all you, because it is throughout the country. But thank you, gentlemen, very much. I look forward to working with you. And at this point, the subcommittee will take a very brief recess to seat the third panel.
Thank you.
Okay, thanks. So as we get ours up, if you have any ideas on anything we're doing, just let me know.
I will, and I want to get